Hello friends, this 1 hour video session will be on the questions that's been asked in NEET 2019 and NEET 2020. Let's take up the first question. Which blood group does this given slide indicate? You have a slide picture given with A antiserum, B antiserum and RH antiserum. You can clearly see you do have agglutination seen in A, agglutination in B and no agglutination in RH. So obviously it's a very simple question. It's going to be AB negative, guys. Let us look at other options as well. Option A, invalid. Option B, Bombay blood group. Option C, O negative. Option D, AB negative. Definitely it is not going to be O negative. It's not going to be Bombay. What will be the appearance of Bombay blood group? That's something you got to understand. When it comes to Bombay blood group, guys, in a slide with Bombay blood group, you're not going to see agglutination in A, you're not going to see agglutination in B as well as in D. Alright, so you have no agglutination in A, B as well as RH. So at the outset, a slide of Bombay blood group resembles, very important, keep this in mind, a slide of Bombay blood group resemble O negative. Alright, so even though a slide resembles O negative, how are we going to ensure it's a Bombay blood group and not a O negative slide? Now, once we get O negative as a result, we got to add in turn H antigen. Alright, after O negative slide is seen, it is essential that we got to go for H antigen testing. We have to add H antigen antibody. In another way, we got to add anti-H. That's very, very important. So in first option, all right, we will be adding antiserum A. In the second drop, we will be adding antiserum B. In the third drop, we will be adding antiserum D, isn't it? So a slide with Bombay blood group will not cross-react with antiserum A, B as well as D, which is why the slide is going to look like, the slide is going to resemble O negative slide. After that, we will be adding antiserum H. That's very important. With adding antiserum H, the remainder H antigen which is present in the RBC membrane is going to cross-react with that antiserum, and we will be seeing clumping only after antiserum H is getting added. Alright guys, that's the most important point in this question. When it comes to the answer, it's a very simple thing. The answer is D, AB negative. Let's move on to the next question. Bainbridge reflex causes option A, bradycardia, option B, decreased cardiac output, option C, decreased venous return, option D, tachycardia. Now it's again a very simple question and a very important question as well. Cardiovascular reflexes are of crucial importance when it comes to PG entrance exam. When it comes to Bainbridge reflex, guys, we have excessive atrial filling, increased atrial blood volume. When the atrial blood volume is more than normal, this excessive blood volume will be sensed by, atrial low pressure receptors. Atrial low pressure receptors. Please understand, this is not baroreceptors. Baroreceptors are high pressure receptors located in carotid body as well as carotid sinus as well as aortic arch. Remember, baroreceptors are located in carotid sinus and aortic arch. They are high pressure receptors. Low pressure receptors are located in atrium itself. It is that low pressure receptor which senses the increased blood volume, and as a consequence these low pressure receptors straight away triggers without involving sympathetic nerve. It straight away triggers sinoatrial node. When SA nodal cells are getting activated, the end result is there is going to be increased heart rate, tachycardia. So friends, as a consequence of increased atrial filling, the ultimate result is going to be tachycardia. Now the ancillary points you need to know in this question is, remember, baroreceptors are high pressure receptors and these high pressure baroreceptors are involved in a very separate reflex called as baroreflex. Alright, baroreceptors are involved in baroreflex. It has got nothing to do with Bainbridge reflex. Point number 1. Point number 2, baroreceptors are located in carotid sinus as well as aortic arch. Point number 2. Point number 3, carotid sinus is again located in external carotid artery. Not in internal, it is located in external carotid arteries. These are the first 3 ancillary points you got to know in baroreceptors. Alright people. The second kind of points you must be familiar with in this question is, as we just saw, Bainbridge reflex. Bainbridge reflex is because of low pressure atrial receptors. Along with atrial receptors, these low pressure receptors are also seen in number 1, superior vena cava, they are also seen in pulmonary artery. Alright, along with atrium, low pressure receptors are also seen in superior vena cava as well as pulmonary artery, guys. So right answer for this question, Bainbridge reflex causes option D, tachycardia. Now moving on to question number 3. C wave in JVP is due to A, atrial systole, B, venous filling, C, right ventricular outflow, D, closure of tricuspid valve due to isovolumetric contraction. It's a straightforward question and the right answer is option D, closure of tricuspid valve due to isovolumetric contraction. Again, a very simple question, guys. We have JVP waves which has got A, C, V, and we do have 2 negative waves. Alright, 2 negative waves, X descent as well as Y descent. Now X descent is of 2 types, X as well as X dash, and we have Y descent, people. Fine. Let's move on to see the waves of JVP. So A wave is due to atrial contraction and initial half of X descent, that means X wave. X wave is due to atrial relaxation. Remember, this X represents either first half of X wave, before C. Alright, now we have C wave. C wave stands for the right answer here, closure of tricuspid valve during isovolumetric contraction. At that point, tricuspid valve not just closes, it even gets bulged into right atrium. So we can clearly see bulging of tricuspid valve into right atrium. bulging of tricuspid valve into right atrium. That's C wave. And we have X dash, which is nothing but second half of X descent. X dash is second half of X descent. Fine. X dash is due to, again, the subsequent phase of ventricular contraction, alright? When ventricular contraction begins, the first phase is isovolumetric contraction, the second phase is rapid ejection. When ventricles goes for rapid ejection, the tricuspid valve that was bulged into right atrium during isovolumetric contraction is now being pulled into the right ventricle during rapid ejection. So practically, tricuspid valve is bulged into right atrium causing C wave. Tricuspid valve is sucked into right ventricle, that's causing X dash, which means second half of X descent. So sucked in tricuspid valve into right ventricle during rapid ejection. That's X dash, guys. And the last one, V wave. V wave is due to venous filling of right atrium. That's very common. And the Y wave, last descent wave, negative wave, is due to opening of tricuspid valve. Opening of tricuspid valve, this happens during passive filling of ventricles. Passive filling of right ventricles. Fine, that's C wave in JVP is due to the questions. Alright, guys. So we have all these waves covered in JVP starting from A, X, C, X dash, V as well as Y. Moving on to the next question. Golgi tendon organ is responsible for. Simple question, guys. Options are muscle tension, pressure, length, proprioception. It's a very simple question. Right answer is option A, muscle tension. Now, the sensory receptors and the modality of sensation they sense and carry is again a very important question, people. Alright, you got to be very familiar with that. Let us get to see all the sensory receptors and the modalities of sensation they carry. Number 1, we have mucinous corpuscles. Mucinous corpuscles. Number 2, we do have Pacinian corpuscles. Number 3, Merkel's cells or Merkel's disc. Number 4, Ruffini endings. Number 5, free nerve endings. Number 6, cross bulb endings. Number 7, Golgi tendon organ. Number 8, muscle spindles. So we have all the sensory receptors and let's get to see what are the sensations they carry. Mucinous corpuscles carries touch. Pacinian corpuscles carries vibration. Merkel cells again carries touch. Ruffini endings carries pressure. Free nerve endings carry pain. Cross bulb endings carries temperature. Golgi tendon organ, TEN, alright. Golgi tendon organ senses muscle tension. So 10 for 10 doctors. Golgi tendon organ senses tension developed in muscles. Tension developed in muscles. While muscle spindle senses change in length of muscles. It senses change in length of muscles. So length for length, LE for LE, TEN for TEN, tendon for tension, muscle spindle, LE for length, guys. Now muscle spindles are also the one that is also called as receptors for proprioception. Remember, when it comes to muscle spindle, you had two kinds of questions in the past. Number one, questions that was using length of the muscle as an option. Number two, questions that was using proprioception as the option. Now, proprioception is a very umbrella term, but actually speaking, the muscle spindle is sensitive for detecting change in length of the muscle. That's going to be your best answer. Now, if you don't see change in length of the muscle as an option, only then you got to go for proprioception. So, if you have a question with both proprioception as well as change in length of a muscle as options, right? It's better to go for change in length of a muscle because that is exactly what is going to trigger a muscle spindle. Alright guys, so these are the sense organs and their respective sensations that's been carried. Next question, a 35-year-old man while watching movie slept with his hand under his head. Which nerve fiber are most susceptible to injury? So the man has slept with his hand under his head, alright. So the weight of head is being getting transmitted over his upper limb and he sustained a nerve injury. Now this is a pressure induced compression and the options are A, B, C, all of the above. Of course, the nerve fibers which are susceptible to injury are all, but the best fiber that undergoes damage is A fibers. Alright, A fibers are most susceptible to pressure. So in this question, which could be your answer? A or D, all of the above? You can have both A as well as D, which seems to be the very correct answer. As I was telling you, when it comes to pressure induced damage or the nerve fibers as per Erlanger-Gasser classification, nerve fiber which are most susceptible to pressure induced damage, and if you consider nerve fiber which are least susceptible to pressure induced damage. Most susceptible as well as least susceptible. We have type A fiber which are very susceptible to pressure in the order of most susceptibility. A alpha followed by A beta followed by A gamma followed by A delta followed by B followed by C. So A alpha is most susceptible, C fibers are least susceptible, guys. So practically speaking, every single nerve fiber is susceptible for damage if it is exposed to high pressures. So which could be the right answer for this question? A or D, all of the above, A, B and C. In this question, it is a simple pressure applied by the subject's own head on his upper limb. So in this question, because the history says the subject has slept with his hand under his head and the pressure is exerted by the head alone, it's not going to be a very tremendous pressure, it's going to be a minimal pressure. Even though when the pressure is minimal, the fibers are getting damaged, which means definitely it cannot be C fiber as well as B fiber. It must be a fiber which has got a very high sensitivity to pressure induced damage, and that's going to be A alpha. So the best answer for this question is answer option A and A fibers. Option A, that is A fibers. Among A, which could be the best choices? You can have alpha followed by beta followed by gamma followed by delta. In this order of susceptibility, the nerve fiber will get damaged if there is a pressure, people. Fine. Moving to the next question. Slowest conduction velocity is seen in which of the following? Option A, preganglionic autonomic. I'm sorry, this is preganglionic autonomic. Option B, postganglionic autonomic. Option C, proprioceptive fibers. Option D, motor fibers. Slowest conduction velocity as per Erlanger-Gasser classification. Alright, so let's take up Erlanger-Gasser classification. Fine. The slowest conduction velocity is seen with C fibers. The Erlanger-Gasser classification takes up A, which consists of alpha, beta, gamma, delta, and then B fiber, and then C fibers. A fibers are densely myelinated. As well as they have very broad axonal diameter. And these two features, density of myelination as well as diameter of an axon, these two features are essential and critical for conduction velocity. Because both myelin as well as the diameter of axon is very big, A fibers are the one which is fastest conducting fibers. So fastest conducting fibers are A fibers. Coming to C fibers. C fibers are completely unmyelinated. And they are the thinnest axon. They have the thinnest axons. Now because the fiber is completely unmyelinated and they have a very, very thin axon, it is the C fiber which is going to be having a very less or least conduction velocity. Fine. So C fiber is the right answer. But for this question, the answer is not about what is the type of fiber. They are asking about the modality with which C fiber is conducting, or based on the modality we got to get to the answer. C fibers have got two features, guys. You know this. It is involved in autonomic transmission as well as it is involved in sensory function. When it comes to autonomic transmissions, C fibers carries postganglionic autonomic. On the sensory front, on the sensory side, C fibers carries deep pain, dull visceral pain, as well as warmth modality. Deep, dull visceral pain as well as warmth. So best answer for this question is option B, postganglionic autonomic, guys. You know very well, proprioception is carried by type 1A as well as type 2 fibers. Motor nerves are A alpha as well as A beta for extrafusal, A gamma for intrafusal. So obviously they are all fast conducting fibers, and the best answer for this question is option B, postganglionic autonomic. Now with aging, what is true for lungs? That's going to be our next question. Options are pulmonary compliance increases, residual volume decreases, fibrosis of interstitial space decreases, mucociliary clearance increases. Out of 4 options, it's a very simple question. With aging, the right answer is option A, pulmonary compliance increases. So what are the features that's going to happen to lung with aging, guys? Number 1, there is going to be age-related loss of elastic tissues. Age-related loss of elastic tissues. When elasticity is getting lost, compliance increases. You guys know this, isn't it? Elasticity of a tissue is inversely related to compliance. So with drop in elasticity, compliance becomes better. So what is compliance as such? In a very colloquial term, compliance is the easiness of expansion. Easiness of expansion, which means how easy it is to inflate a lung. That is what is called as compliance. So when a lung becomes more and more elastic, it becomes very difficult to inflate. When the elastic tissues are gone, lungs become free, lungs become flabby, it is very easy to inflate the lung. So with age, there is going to be a drop in elasticity and a proportional rise in compliance. And hence A is the right answer. Coming to option B, residual volume increases. That's again a problem. Here, as the elasticity of lungs are gone, the ability of lung to recoil becomes difficult. Alright, so when a subject has got when a lung which has lost its elasticity becomes more baggy, the ability of lung to recoil decreases. Only when a lung recoil, we can able to breathe the air out. When the recoiling tendency is getting lesser, the air is not going to go out of our lung, it is going to stay in the lung itself, and that is going to increase residual volume. So again, age-related loss of elastic tissues, and this age-related loss of elastic tissue is going to contribute to increase in residual volume. And please remember, because residual volume increases, there is going to be a proportional rise in functional residual capacity. There is going to be a rise in functional residual capacity. As a consequence, there is going to be a rise in total lung capacity as well. There is going to be a rise in total lung capacity. FRC increases, total lung capacity increases. Alright, doctors. Now, just because residual volume is more, total lung capacity is more, the chest is going to look like barrel shaped. So, with age, subjects will develop barrel shaped chest. And you know the reason why. Fine, that's option B. Coming to option C, fibrosis of interstitial space decreases. No guys, with aging, the ability of healing decreases. The amount of stem cells decreases. So with drop in stem cells, with age related decrease in, alright, with age related drop in stem cell population. Whenever there is a damage to respiratory cells or epithelium, we do not have enough stem cells to repair the damage. That leads to formation and deposition of fibrocytes in the site of injury. So there is going to be excessive deposition of fibrocytes. So ideally speaking, fibrosis of interstitial space must be increased and not decreases. Similarly, residual volume must increase and not decrease. So again, option B, option C are wrong in this case. Option D, mucociliary clearance. You know there is a mucociliary escalator, which is nothing but cilia powered by dynein. So that cilia is going to beat up, and the soot particles, dust particles, antigens are going to be cleared off the respiratory tract. With age, the ability of cilia to move and the ability of dynein to power the cilia is going to be decreased. With ciliary dyskinesia, mucociliary escalator function remains static or getting progressively weaker and decreased. That's how patients very frequently develop respiratory tract infections, old age people. The reason behind it is the deficiency of dynein or inability of dynein and cilia to clear respiratory passages of dust and infections. So again, mucociliary clearance must be decreased in old age. So best answer for this question is option A, pulmonary compliance is getting increased, guys. Moving on to next question. Functional residual capacity is lung volume after normal inspiration, after normal expiration, after forceful inspiration, after forceful expiration. The right answer is after normal expiration. Functional residual capacity of lung is lung volume after normal expiration. Let's get to see lung volumes as well as capacities. Lung volumes and capacities. So in this graph, let's take up a residual volume of 1 liter which cannot be blown out. So 0, 1, 2, 3, 4, 5 and 6 liters. Now 6 liters is the total lung capacity. The last 1 liter is residual volume which cannot be blown out. We have another 1.5 liters which is going to be the expiratory reserve volume. So this volume is expiratory reserve volume. Alright, expiratory reserve volume is going to be 1.5 liters and residual volume is going to be 1 liters. You get this. Now from the expiratory reserve volume, if you see this position where there is going to be 2.5 liters of air in the lung remaining, 1.5 liters of expiratory reserve and 1 liter of residual volume, together it is going to be 2.5 liters, isn't it? This 2.5 liters of air is called as functional residual capacity. .5 liters is functional residual capacity, doctors. Fine. This 2.5 liters is seen at the end of normal expiration, which means the functional residual capacity is the space in lung where lung is at rest, which means at the end of normal expiration. Normal expiration, which can also be called as tidal expiration. Both are synonymous terminologies, normal expiration or tidal expiration, guys. So functional residual capacity is the lung volume where the lungs are not getting exposed to any kinds of pressures. Usually in thorax, lungs do have a natural tendency to recoil inward. Chest wall, thorax do have a natural tendency to recoil outwards. Alright. So when these two opposing forces are existing, we have a pleural cavity with parietal pleura connected to chest wall, visceral pleura connected to lungs. So parietal pleura moves along with chest wall, recoiling outward. Visceral pleura is moving along with lung, recoiling inward. Just because these two opposing structures are connected by pleural membrane, the chest wall as well as lung remain in a midline and these two forces are equally balanced. So the natural inward recoiling tendency of lung is balanced by natural outward recoiling tendency of chest wall. Thereby the thorax will remain in a volume of 2.5 liters. That's another very important point you got to be sure and clear about functional residual capacity. Please remember, when it comes to functional residual capacity, the outward recoiling tendency of chest wall is perfectly balanced and equalized by inward recoiling tendency of lung. Alright, that volume or that capacity of lung is called as functional residual capacity. When the net force is zero, that's another word you need to remember, the net force. The net force is zero, the lungs are at rest. So at functional residual capacity, lungs are at resting state, because there is no net force. Neither lungs are overacting nor chest wall is overacting. These two structures are balancing each other's recoiling tendency. Alright, that's functional residual capacity, and never forget all the points that we just discussed. From the functional residual capacity, if the subject breathes out for another 500 ml, This volume is called as tidal volume, and tidal volume is nothing but 500 ml. So tidal volume is normal inspiration, normal expiration, normal inspiration, normal expiration. That's tidal volume, guys. If a subject could able to inhale beyond tidal inspiration, he can able to take up another 3 liters of air max. Apart from the 500 ml of air that he could able to inhale with tidal inspiration, a subject could able to still inhale another 3 liters of air, which we call this as inspiratory reserve volume. Inspiratory reserve volume, and inspiratory reserve volume is going to be 3 liters. It's going to be 3 liters. Alright, so that's lung volume, guys. We have inspiratory reserve volume, tidal volume, expiratory reserve volume, as well as residual volume. When it comes to capacities, inspiratory reserve volume plus tidal volume, it's going to be inspiratory capacity. And 3 liters plus 500 ml, that's going to be 3.5 liters. And people, we also do have vital capacity that includes everything except residual volume. So inspiratory reserve plus tidal plus expiratory reserve volume. Together it is vital capacity with a value of about 5 liters. And the last one is functional residual capacity, you know that, and total lung capacity that includes the complete amount of air. Alright, the complete amount of air that can be filled in lungs. Alright, so 6 liters is what is called as total lung capacity. Total lung capacity. Fine, guys, that's the question. Now moving on to the next question. In pulmonary function test, values of FEV1 is 1.3 liters, FVC is 3.9 liter, diagnosis is. Again, it's a simple question. We have forced expiratory volume in first second and forced vital capacity. The ratio FEV1 by FVC ratio is the diagnostic hallmark with which you can able to make up a diagnosis of obstructive lung disease or restrictive lung disease. Please understand the normal value also first. Normal value. Normal FEV1 by FVC is going to be 0.8. In obstructive lung disease, the hallmark feature and the diagnostic criteria itself is the ratio must be less than 0.7. Alright, FEV1 by FVC ratio of 0.7 or less is the diagnostic standpoint for obstructive lung disease. In case of restrictive lung diseases, the value can be 0.8 normal value, or it can be even more than 0.8. That's a very important finding in restrictive lung disease. Alright, the value can be either normal 0.8 or it can be even more than normal value, people. It can be even more than normal value. That's restrictive lung disease. So let's get back to the question here. We have FEV1, that's 1.3 liters, and FVC 3.9 liters, and the ratio comes down to 0.3. When the ratio is 0.3, which is less than 0.7, it's obviously a case of obstructive lung disease. B is the right answer for this question. Obstructive lung disease is the right answer for this question, guys. So remember, FEV1 by FVC ratio is the standpoint with which we can able to say whether a patient's the respiratory distress or difficulty is because of obstructive lung disease or restrictive lung disease, guys. Now, in forceful expiration, which of the following neuron gets fired? It's a straightforward question. No bigger concept or logic. We have ventral respiratory group of nucleus, which is exclusively concerned with expiration. specifically speaking, voluntary expiration. Voluntary expiration or active expiration. Alright, voluntary breathing out, active breathing out are mediated by ventral respiratory group of nucleus, while dorsal respiratory group of nucleus is involved in inspiration, guys. Dorsal respiratory group of nucleus is exclusively involved in inspiration. Ventral respiratory group is involved in expiration. Now, you need to understand this within ventral respiratory group. As we just discussed, within ventral respiratory group, we have exclusive VRG regions. Exclusive VRG regions, ventral respiratory group, which are concerned with expiration. Now, in between, we have a particular region called as pre-Bodzinger complex. And pre-Bodzinger complex is concerned with inspiration, guys. Even though inspiration is exclusively controlled by dorsal respiratory group, within ventral respiratory group, there is a region called pre-Bodzinger complex that is also concerned with inspiration. And this pre-Bodzinger complex is called as pacemaker of respiration. It's called as pacemaker of respiration. Pneumotaxic center, you guys know this very well. Pneumotaxic center is something that is involved in inhibiting apneustic centers. When apneustic center is getting inhibited, inspiratory signals are stopped. Inspiratory signals are blunted. So practically, pneumotaxic center, by inhibiting apneustic center, prevents overexpansion of lung, prevent overstimulation of respiratory neurons. That's pneumotaxic center. Chemoreceptors. By activation of chemoreceptor, we will be having voluntary inspiration more. Alright. So when chemoreceptors are getting activated, patients will have increased ventilation, both inspiration as well as expiration in that sense. But more than chemoreceptor, ventral respiratory group of nucleus are the one which do have a direct activity over expiratory neurons. So even though chemoreceptors are getting activated, this will exert its action through ventral respiratory group as well as dorsal respiratory group. So people, we have chemoreceptors which are triggered by three factors. Hypoxia, where partial pressure of oxygen is going to be less than 60 millimeters of mercury. Hypercapnia, where partial pressure of arterial carbon dioxide is going to be 40 millimeters of mercury. And acidosis, pH of arterial blood is going to be less than 7.35. All these factors are triggers for peripheral chemoreceptors. Peripheral chemoreceptors. When peripheral chemoreceptors are getting triggered, they go and excite dorsal respiratory group, they go and excite ventral respiratory group. Thereby, because of dorsal respiratory group excitation, there is going to be increase in inspiratory signals. Because of ventral respiratory group excitation, there is going to be increase in expiratory signals. So even though chemoreceptors do contribute to hyperventilation, tachypnea, this effect is executed by respiratory groups of nucleus and not by chemoreceptors straight away, which is why between ventral respiratory group and chemoreceptors, the best answer is going to be ventral respiratory group, people. Fine. The next question. Peripheral chemoreceptor respond to hypoxia using which channel? Calcium, potassium, sodium, chloride. The right answer is B, potassium channel, people. We have a cell in chemoreceptors. These cells are called as glomus cells. And this glomus cell do have a channel, a potassium channel, and this potassium channel is called as oxygen sensitive or ATP sensitive. ATP sensitive potassium channels. Very important. These channels are usually in an open state. Say for example, when we have enough oxygen in the extracellular fluid of glomus cell, this oxygen enters into glomus cell by diffusion. Oxygen straight away keep the channel to stay open. Oxygen straight away keep the channel to stay open. If not, oxygen involved in facilitating glycolysis, aerobic glycolysis or other oxidative phosphorylation mechanism where there is going to be increased synthesis of adenosine triphosphate. In the presence of excessive oxygen, in the presence of excessive adenosine triphosphate, the potassium channels are kept in an open state. Since the potassium channels are kept in an open state, potassium within the cell due to concentration gradient keep getting fluxed out. Potassium keeps getting fluxed out. As more potassium is leaking out of the cell will be in a state of hyperpolarization. There will not be any trigger, there will not be any activity. When this patient develops hypoxia, for example, there is going to be absence of oxygen, guys. When oxygen is not present, when oxygen is absent, there is not going to be enough oxygen inside the cell. There is not going to be enough ATP inside the cell. In these mechanisms, in these circumstances, the gate gets closed. The gate will not remain open anymore. The gate will become closed. Once the gate gets closed, you cannot have any efflux of potassium. As a consequence, we will find all the potassium to get accumulated within the cell itself. When the intracellular potassium level is more, the cell will become depolarized. A depolarized glomus cell is going to trigger afferent activity in glossopharyngeal nerve and vagus nerve. That is how chemoreceptor senses hypoxia, gets activated. As a consequence, glossopharyngeal and vagus carries that activation to respiratory centers. Thereby, there is going to be triggering of respiratory neurons. Patients will go for hyperventilation. More the ramp of inspiration, more the ramp of expiration. That is exactly how peripheral chemoreceptor functions, and the best answer for this question is option B, potassium channels. Moving on to next question. When V by Q becomes infinite, true in alveoli is. What is V by Q? Ventilation perfusion ratio. Alright, let's get to the answer first. Options A. Partial pressure of oxygen and carbon dioxide becomes equal. Alright, option B. Partial pressure of oxygen is around 159 millimeters of mercury and carbon dioxide is 40 millimeters of mercury. Option C. Oxygen doesn't diffuse to blood and carbon dioxide doesn't diffuse to alveoli. Option D. Partial pressures of oxygen and carbon dioxide become equal to air in dead space. Alright people, these are all the options that we do have. The best answer is option C. Anyway, let's get to see why option C is the right answer. Now, V by Q becomes infinite. That itself tells us that this patient is having dead spaces. Alveolar dead space. So when it comes to alveolar dead space, what happens is we have an alveoli, and this alveoli is perfused by a pulmonary capillary. Now, whenever a pulmonary capillary becomes obstructed, embolism, thrombus, or when there is any microocclusions, or there is no blood flow into pulmonary artery at all, right ventricular failure, pulmonary artery stenosis, anyway, in any circumstance when there is no blood in pulmonary artery or pulmonary capillaries, the capillary will get shut closed. The capillary will not remain open, the capillary will be closed. Such a condition is called as dead space. Please don't assume dead space as blocked alveoli. Dead space doesn't mean blocked alveoli, it means blocked pulmonary capillary or emptied pulmonary capillary. In such circumstance, you cannot have movement of oxygen from the alveoli into capillary because the capillary itself is closed. Since the capillary is closed, there is no oxygen transfer. Since capillary is closed, there is no blood flow into capillary. Without blood, there is no carbon dioxide at all. So there is no carbon dioxide transfer as well because the capillaries are closed, which is why we have taken option C as the best answer. Let us analyze option A. Partial pressure of oxygen and carbon dioxide become equal. Is that so, guys? Never, never. Partial pressure of oxygen in alveoli is going to be 102 millimeters of mercury. Partial pressure of carbon dioxide in alveoli is going to be 40 millimeters of mercury. These two are the values of partial pressures in alveoli. Are they equal? No. So option A is wrong statement. Option B. Oxygen is around 159 and carbon dioxide around 40. Wrong. Oxygen is going to be 102. So option B is also wrong. Option D. Partial pressure of oxygen and carbon dioxide become equal to air. Alright. In dead spaces, the partial pressure of oxygen and carbon dioxide, does it equals to air, guys? No. When it comes to air, partial pressure of oxygen is going to be 149 millimeters of mercury. Partial pressure of carbon dioxide is going to be practically 0 millimeters of mercury. So again, they are not going to be equal to air. D is also wrong. So the best answer is going to be C. Alright. Oxygen doesn't diffuse to blood. Carbon dioxide doesn't diffuse to alveoli. That is exactly what is happening in dead spaces, doctors. That's it. Coming to the next question. Vasopressin acts through which channel in collecting duct? Aquaporin 1, 2, GLUT 3, GLUT 4. Alright, when it comes to vasopressin, the whole points essential for solving questions on physiology of vasopressin is very limited, very simple as well. Now, vasopressin do have action that can be executed by three types of receptors. Alright, number one, V1 receptors. Number 2, V2 receptors. Number 3, V3 receptors, also called as V1B receptors. V3 or V1B receptors. By acting through V1 receptor, alright, vasopressin increases intracellular calcium. Increases intracellular calcium. Using calcium as a second messenger, vasopressin is involved in constriction of smooth muscles. Constriction of smooth muscles in blood vessels. When smooth muscles in blood vessels are getting constricted, this will produce vasoconstriction. Through V2 receptors. Through V2 receptor, vasopressin increases the level of cyclic AMP, adenosine monophosphate. With the levels of cyclic AMP, vasopressin increases the number of aquaporin 2, number of aquaporin type 2 in principal cells. When the number of aquaporin type 2 channels in principal cells are increased, this ultimately leads to increased water reabsorption. Water reabsorption. This is exactly why vasopressin is also called as antidiuretic hormone, because it increases water reabsorption via principal cells through the channel aquaporin type 2, and that's the right answer for this question. Coming to the third receptor, alright, V3 receptor or V1B receptor. Through V3 or V1B receptor, it's a very simple action. There is going to be increase in stimulation of ACTH, increased adrenocortic trophic hormone production happening in anterior pituitary gland. So practically, V1B receptors are located in anterior pituitary corticotropes. These corticotropes cells produces pro-opiomelanocortin, which gets cleaved by pituitary specific proteases that breaks down pro-opiomelanocortin into adrenocorticotrophic hormone. And that is exactly how vasopressin influences secretion of ACTH, alright, through V1B receptor, also called as V3 receptor. This is on one side, guys. On the other hand, when it comes to aquaporins, you also need to be very familiar with aquaporins. There are 4 kinds of aquaporins. Aquaporin 1, 2, 3 and 4. Out of 4 classes of aquaporins, it is aquaporin type 2 which is alone influenced by antidiuretic hormone. None of the other aquaporins are influenced by ADH. Remember, ADH own and only influences aquaporin type 2 and no other hormones, guys. Alright, so that completes our question discussion on NEET 19 as well as 20 papers, guys. So I hope this will be of decent help for you when it comes to your revision of question papers in 19 and 20. And guys, if you need any more help from our side, if you need any more questions, if you need any more topic discussions, we sincerely request you guys to share your inputs as well as your queries to our website or to our Telegram group. We'll be happy to help you guys out. So that completes our discussion. Best wishes and good luck, guys. Thank you very much from DBMCI and eGurukul. Thank you, guys.